lunch are Dr. Wang. She sent you off to lunch, and she will welcome you back. And her talk's going to review at a high level this notion of monophasic versus recurring disorders, and how we classify them and how we think about them biologically and how they impact you as individual patients. And so I'm delighted to bring back Cindy Wang.
All right, so let me, it's going. All right, so I was asked to give this talk in place of someone else, and hopefully, I'm not sure if this is what it was intended, but I thought I would dive into sort of what I feel is interesting between the monophasic and the recurrent disorders that we've seen and heard about today. Still my disclosure. So I thought it would be helpful to start by trying to define what a relapse really is, also known as attack, also known as an exacerbation or a flare. When I think of it, this should represent a new episode of inflammation within the central nervous system. I think someone had pointed out earlier that these symptoms should last more than 24 hours. If we were to look in the spinal fluid, there may be suggestions of too many immune cells there. If we looked at neuroimaging, it might show new lesions and lesions that take up contrast, meaning that they're active, and there's some blood-brain barrier breakdown. And in the setting of a certain relapse, the best way of treating these symptoms would be things like steroids, IVIG, and plasma exchange to reduce not only the damage from the attack, but also hopefully to hasten recovery. We get a question a lot about symptoms that don't quite fit that pattern I described. And most of the language calls it, a pseudo-relapse, pseudo-exacerbation, which is usually a temporary increase in symptoms in the setting of something that kicks your body out of its kind of physiological comfort zone. So being sick, with a URI or a UTI, living in Texas during the months of July to late September, and then lack of sleep is a big one. Just in general, life, all the things that life throws at you. With those moments, your body, which probably is already trying to do everything it can to compensate with the disability that you may have gained from your prior incident, has to really ramp it up. And that's when things don't always, you can't completely mask all the symptoms that you may be having. The good thing about pseudo-relapse is that typically when you restore everything to sort of your body's normal state by getting over your illness, going into a cool area, getting more sleep, then those symptoms generally go away. For the most part, these pseudo-relapses should represent symptoms that you've already had. So looking a little bit at how we name neuroimmunological diseases, when they are named by location, encephalitis, optic-neuritis, transversemyelitis, those are often the idiopathic forms if we can't put it into a bucket of a different condition, versus syndromes where we know the constellation of features that come with the condition, namely multiple sclerosis, Animo, SD. The other ones don't necessarily have a relapsing course, but I think this might give you kind of an understanding about how the naming conventions go. This was a diagram developed by one of our senior research nurses, Tricia Plum. So I'd like to thank her for helping with this and trying to just show in a schematic way what tends to be on the recurrent side of things and what tends to be on the monophasic side. So aquaportin for Animo, definitely this is a condition that I almost never will let my patients be off immunosuppression. That just makes me very, very nervous because as we've been told by many people that these attacks are very severe and they can lead to the bulk of the disability in the condition. Similarly with multiple sclerosis, it seems that with disease-modifying therapy, we can improve the outcome of their disease course and prevent secondary progression, or at least stave that off as much as possible. Recurrent optic neuritis was something that wasn't really well understood until MOG antibody assays became more available, and it seems that those patients probably have a MOG antibody-related condition and are at risk for relapsing. Then you can have idiopathic optic neuritis, idiopathic transverse myelitis, acute disseminated encephalomyelitis, and then acute flaccid myelitis, in which I've really never seen another attack. And I think it really goes into why the mechanism is different, an infectious mechanism versus an autoimmune one. So this is just kind of stating it a little bit more, expanding on the idea with monophasic, your immune system may get tripped up one time, but it really shouldn't misfire or misbehave any further, and those are the conditions that we see. So the goal of treating a monophasic illness is to treat the acute episode with all those treatments we've talked about, and then kind of see how things stand after that treatment, and if there are any lingering symptoms, then to use our best ways of promoting reduction of those symptoms and promoting healthful behaviors. When it comes to relapsing conditions, we want to do all of those things, but also talk with the patient about a long-term therapy that will decrease their chance of having more episodes of inflammation. I don't want to minimize the fact that just because it's a monophasic illness, that there isn't significant changes that can result from these conditions. So this group looked at monophasic demyelination, I think primarily ADEM in children, and found that it did reduce their brain growth. And then I think a question for many of the clinicians in the room is, if we could provide you some extra information at the outset of, does your condition look like a monophasic or a relapsing condition, that might give you a little bit more peace of mind. So the ways that we do that are trying to make, a pattern out of the things that we see from your clinical presentation, from perhaps your demographic features, from what your laboratory studies and neuroimaging show us, and then put that all kind of together. And it's really been revolutionary for these aquaporin 4 and MOG antibodies to be detected, because they're, often if you get one positive, that kind of, that kind of seals the deal, and you may not have to keep looking for other things. And then also doing surveillance for additional clinical attacks is important regardless of what the cause is. This is probably not going to project well, but I just wanted to highlight, predictors of multiple sclerosis, those oligoclonal bands that we have talked about, predictors of Animo, the aquaporin 4 antibody being present, and then predictors of relapses of MOG, really having that persistent MOG antibody. I had just a few brief slides on each of the conditions I talked about. These have been covered in greater detail by other people, but I'll just point out that transverse myelitis, when just called transverse myelitis, is typically an idiopathic process, but it can be the first presentation of a relapsing condition. Some poor prognostic factors include having it at a young age, having the severity of the symptoms come on very quickly, and then enhancing lesions, which mean that there's been enough injury to have some blood-brain barrier breakdown. So these examples of imaging already tell us some clues about what kind of disease that they might have. So this is, here's what we call skip lesions. They're round, they're usually less than one vertebral segment in length. And yeah, they skip, they may be at different points in the spinal cord. And that is very characteristic of multiple sclerosis. In contrast, we have here NMOSD, which is billed as a longitudinally extensive transverse myelitis, so greater than 3 of these vertebral segments. In this individual, I think it virtually just goes down the whole spinal cord. So I covered acute disseminated encephalomyelitis already, so I will kind of breeze through this part. Again, encephalopathy is a really big defining feature of this condition, and the overwhelming majority tends to be monophasic, but it's those ones that we assess MOG and see that they're positive, they really need long-term follow-up. So yeah, monophasic ADEM means no new symptoms, no new MRI changes after the first 3 months, and the course of ADEM being monophasic is about 85%. Here's some different depictions of ADEM of varying levels of severity. Most of these look pretty bad, but that just shows, how striking those initial changes can be. So anti-MOG syndromes, they're present in children who have acute demyelinating syndromes other than MS, other than NMOSD. They can take on presentations that overlap with those syndromes, but the way we distinguish it is by that positive MOG test. And I think the story is still kind of being written in terms of how far do we need to monitor these MOG antibodies? If it hasn't gone away in 6 months, 12 months, is it going to be there forever? If it's there forever, does it really increase the risk of a particular child to have another attack? And even if it did, would we have a good way to know when that attack would occur? Because if we were to be aggressive and want to treat, then that could be many years of immunosuppression that we don't know if it actually had any benefit. Here are a few other examples. I think Dr. Blackburn talked a little bit about how while MOG can also be longitudinally extensive, it tends to have a predilection toward the lower part of the spinal cord called the conus medullaris. And then, we and Mayo have reported that there are these patterns on cross-section of the spinal cord that do look like they kind of circumscribe the gray matter of the cord, similar to AFM. Here are just example of what the brain lesions in MOG disease can look like. When it comes to optic neuritis, the pattern of MOG antibody optic neuritis does differ a bit from Animo. It's usually in the anterior section of the optic nerve prior to the chiasm. So here, the arrow sign that you see is where these nerves are inflamed. MOG has a tendency also to be bilateral, so sometimes that's a clue. And then this is indicating a deep gray matter lesion. So the demographics of this is relapsing MOG patients. This includes pediatrics and adult cohort, but there seems to be a skew toward female gender. The ethnicity breakdown is I think pretty representative of the nations that they did the surveillance. So not necessarily a Caucasian or a non-Caucasian bias. And the presenting phenotype differ, with more of the children having an ADEM-like presentation and the older patients having optic neuritis. This graph shows when they followed these cohorts over time that it tended to look like the younger patients had more frequent relapses. Each of these going down means they're having an attack. And then in this one, it shows that I think this one, sorry, I can't really read. Should know next time not to put such small pictures. That I think optic neuritis tends to be, relapsing. Yeah, optic neuritis. That phenotype somehow likes to, have more frequent relapses as compared to something like transversemyelitis or ADEM. Dr. Blackburn showed this. I think this is encouraging. It's definitely, not a slam dunk. If all of these treatments were effective, then we would see a really big drop of, the pre-annualized relapse rate go down. This is the most striking one, and that was also always kind of question, like, is IVIG really that helpful? Is IVIG working through a different mechanism, perhaps preventing infections, and that maybe the infections themselves are what's triggering the attack? I personally haven't had much success in using this because the child I tried to use on it had aseptic meningitis and could not tolerate the treatment. And we also have, in the United States here, a IVIG shortage. So you've heard a lot from Dr. Levy about Animo, so I won't belabor this. Older age group, and then some of the other conditions that we see more prevalent in non-Caucasians and females are highly disproportionately affected. The majority of the disability comes from incomplete recovery from relapses. So this is the 2015 NMOSD diagnostic criteria. When you have a positive aquaporin 4 IgG or antibody, it's a lot, lot less stringent. So you just need to have that antibody and one of these core clinical characteristics. However, if you're seronegative for the antibody, it's more rigorous. You need to have, one of the two core characteristics has to be optic neuritis, transversemyelitis, or air post-Rima syndrome. There's also other neuroimaging components that you have to satisfy, and just a general statement about excluding things that can look like NMO that aren't it. So here are some pictures of what NMO looks like. Again, a long segment, area post-Rima here. It's sort of in the middle of this cord. I think this was just to show that even small or shorter lesions can be consistent with NMO. It really just has to do with when the MRI is obtained. So if you obtained it too early or too late, so that maybe the lesions are coalescing or resolving, you may not get a over 3 vertebral segment piece. And then within the brain, neuromyelitis optica likes to go to certain places, like around this third ventricle here, near the hypothalamus. So here's some characteristic ways that it could involve the brain. I want to throw, kind of a new player on the field, and we talked about how bad the naming conventions are. This one is a mouthful too. But this is an antibody that was discovered in a population of people who had inflammatory like meningo, like a meningitis, as well as encephalomyelitis, and then they sometimes had optic disc edema too. The age averaged around 40 years. It was a pretty equal male to female distribution. They saw a notable association with tumors, particular teratomas. If people know about anti-NMDA, this is an autoimmune encephalitis that also can be triggered by teratomas. So they saw that within this population, they sometimes had co-expression of other antibodies, including NMDA and aquaporin 4. Radiographically, it has very distinct patterns of contrast. They call this radial perivascular enhancement. You can kind of see this from a different angle too. And I think I just wanted to not necessarily go through any of these in great detail, but these are other types of inflammatory disorders that may have brain involvement, but they're more typically systemic illnesses, so they can affect other things like soft tissues, bones, joints, so forth. And then also thinking about the non-inflammatory mimics, degenerative disc disease causing compression, can have a spinal cord stroke, which Dr. Pardo will be talking to us about, I think, next. So in summary, monophasic illnesses represent one time episode of inflammation and demyelination. Relapsing disorders may represent a persistent dysfunction in the immune system leading to recurrent attacks. It's really important to really understand pattern recognition in these conditions, since if you know the typical features of the person, their imaging findings, and their laboratory studies that would fit into one of these known syndromes, then that can help take away a lot of the anxiety out of what my diagnosis is and what the future holds. So Yes, and testing for those relapsing disorders that we can do with antibodies, including aquaporin-4 and MOG, are supremely important to this. Just want to briefly talk a little bit about what the future might hold within the monophasic and relapsing disorders group. Within monophasic disorders, I think we have to better understand what predictors of disease severity during the acute attack and tailor treatment to that. So, hopefully we can get the best outcome. For people who've had their attack, years ago, and as they're getting older and not feeling as well, I think there's a role for things that we can do to improve neuroprotection. So how do we make the best use of what you have? How do we get diet, exercise, sleep, and things like that to allow you to compensate as much as you can with the disability that you have? And then I think it's really exciting that there are remyelinating therapies, not only drugs, but also use of glial-restricted stem cells that are in the works. As it relates to relapsing disorders, very exciting that there's 3 different medications with different mechanisms of action being rolled out for NMOSD. And it makes me think that, now that we have a better understanding of MOG, we can identify these patients, whether that should also happen for MOG. And that's it. Oh, okay. We can take 2 questions. Aquaporin-4 NMO. Yeah. Oh, yeah. Do I consider all forms of aquaporin-4 NMO to be relapsing? I think, I've not been so brave enough that I don't put those patients on something because I've seen how bad those attacks can be. And I think a lot of the, historical literature had these, very like painting the picture of people becoming very disabled. I don't know if I know enough about the molecular underpinnings of that, but yeah, I pretty much treat everybody as a potential for relapse. So I would put them on lifelong immunosuppression. I mean, I think what we want to work toward is something that is a way to tolerize your body so that it could represent something you get and then fix that problem, and that would look more like a cure, but yeah.
With regard to the treatment options that you've got with the steroids, the Plex and the IVIG, how important is the Plex component? Because we tend to use that very infrequently in Australia compared to what I'm hearing today.
Yeah, no, I think I had the fortune of doing my fellowship kind of with the opposite pattern of use. I think definitely for aquaporin-4, because we know that that antibody is pathogenic, and the longer it stays around, the more ability it can do damage. I don't know. We've only seen a little bit of MOG data, and I think it looks beneficial, but I feel MOG is more responsive to steroids and sometimes can get completely better just with steroids alone. And then we don't really use much IVIG, so yeah, I think it does depend on the mechanism of the illness. So if it is primarily antibody driven and these antibodies are known to wreak havoc if they're in the human too long, then plasma exchange is probably the best and most aggressive way to reduce that level of injury.